Thank you. Good afternoon. I hope you stay on with me for a few minutes because we are over time and I know you are tired and you're all sitting on the right side of the room, which I don't quite understand why. But anyway, I'm really glad that Ken started to mention the challenges with testing and key populations. And so what I'm going to present you today is the evidence that have been gathered by the community of people living with HIV in regards to specific challenges and also their perceptions about HIV testing and what are the key barriers that prevent them from accessing services. And I would like to take the opportunity to also thank IO for inviting me to be part of this panel and also for GNP Plus to be working closely on the campaign. We have amazing young people profile featured in your work, so they're really happy, and our executive directors have also been part of the campaign as well. Just to talk a little bit about the evidence that we gathered through the tool, which is called People Living with HIV Stigma Index. So the Stigma Index is implemented, it was developed in partnership between GNP Plus, IPPF, ICW, and all community networks. Is actually the country positive network that takes ownership and leadership and implement this to get the evidence from other people living with HIV to understand the extent to which stigma and discriminations really affects their life in various levels. And it provides evidence for the policy development, but most importantly, what the process is for the stigma index for getting information is really empowering process when person living with HIV talk with other person living with HIV about fear, about stigma discrimination and how one person overcomes it. So it's much about the data, but it's also much about empowering process for people living with HIV. And from that process, we try to do a cross-analysis looking at the informant that are key population living with HIV. So we have found that individual level barriers to HIV testing exist among key populations, and mostly because the intersecting stigma this wishes to occur when the stigma related to key populations membership interacts with the HIV-related stigma. And this makes it even more complicated for the persons to decide to go to test and be linked to care. And in many countries, there also a lot of report about delayed accessing medical care because they had previous bad experience with health workers and they fear that they will be treated badly and their status will be disclosed without consent. The study that we do in Eastern Europe and Central Asia, we look at Ukraine, Turkey, and we found that a lot of key population are fear of the criminal laws that could be enforced against them, and especially when the results come back positive. And in Poland, Turkey, Ukraine, sex workers are experiencing a lot of violence from their intimate partners and their clients. When we look at the individual barriers to testing, I think this is coming from the study that was done by the Indian Network of People Living with HIV, and this was the data back in 2008. It hasn't changed that much, and the community of people who use drugs do fear about the potential positive results. They also have issues around, they said it's a mental torture. You're already using drugs, you're already experiencing such great stigma, and having to know that you are going to be in need of a lifetime treatment even scared them further. So they decided not to get tested at all. Or some of the community groups in this study in Chennai, India, also was not well aware of the effectiveness of ART. They still have really little information about the antiretrovirals and how that can keep them healthy. And the more pressing issues that really kills them is overdose and drug-dependent complications. So as you can see, they would think about drug first. This is where the third point come in. The people who use drug will give precedence to drug use and not health and HIV because they're not immediate priorities. And as long as they can get drugs on the first place, I think the HIV is in the letter. And they're going for HIV testing, they fear that if results come back positive, then they would have to go to they would have another reasons to go to rehab or to get detox. So HIV is an added burden in their perception. We also know that the sex worker communities, for example, there would be issues around the social norms that if you are a sex worker and you are also living with HIV, I think there's stigma even within that communities because you will spoil the clients will be scared and will not be coming forward for services. So I think even within the community groups, there are also stigma related to the potential positive results of HIV test. And when we look at the healthcare system barriers, as I mentioned earlier, the issues around the attitude and discrimination of the health workers, the location for HIV testing center is particularly pertinent, serious problem because a lot of communities of key population do not want to access services in localities where they could be identified, where the neighbors would know that if the results come back are positive. A lot of them also have issues around accessing services at the hours in government hospitals that are mostly close of the time when they're available to go. And what is interesting here is also the waiting time for counseling and testing and getting test results play a particular role for one person to decide whether they should go for testing or not. If you go for test and you have to wait 3 days to get a test result or to come back to the capital again to learn about your HIV status, it is really likely that the person will not show up at the test facility and have the doubt in mind and continue to have it. And what we have also found in our study is that no counseling is made available at all for key population, and no one knows how to provide counseling for men who have sex with men, how to talk about anal sex, for example. I think that's quite an area that still needs to be informed. And we have an issue around policy program and legal barriers, which I guess is quite clear working on HIV. These are added burdens to the community-based organizations who provide testing. There's no funding. And I think what's interesting here, I hope you're not sleeping yet, is the policy restrictions that some countries doesn't even allow community health workers to perform rapid testing. And this prevents a lot of community groups to do testing to key populations. And I think I'm running out of time, but I just want to show you one slide that just has been presented at our satellite that was organized by GNP+. This is the work that was done by the Asia Pacific Network of People Living with HIV, and this is a preliminary finding from the Community Access to Treatment and Care Support Study of APN+ that has been implemented since 2012 and is supported by the Global Fund. What it does is it works with 7 national people living with HIV networks to really try to understand what the issue around adherence, testing, pre-ART care, treatment literacy, and it involved 7,843 people living with HIV in this study, and a majority of them are key populations. So you started to see the trend around in Laos, there's still a lot of issues around be presented late at facility just after their partner or their spouse has identified their HIV, they're living with HIV, or countries like Pakistan, there's still the issue around testing without the consent, which I guess we have been advocating so hard, but in practice, I think this still happens. And the uniqueness of the Asia-Pacific region is that population are really mobile. So you started to see the issue around overseas working, having to get tested, going back home with HIV positive results, or not being able to seek care or return to the country of their work. And just a few slides say that GNP+ is in partnership with the WHO to develop the key population guidelines. So we went through some of the examples of community-based service delivery that really reach out to key population, men who have sex with men, sex worker, people who use drugs, transgender, and also people in prison settings. And I think some of the campaigns which have been presented here at this conference is really mobilizing, generating demand for HIV testing and get people to get tests. And this is some of the example from Thailand, which is supported by Thai Red Cross called Adam's Love, which has more than 500,000 people visiting the website, and the testing sites reported as well that because they have seen the website, they understand the messages, and then they come and get tested. And the the most important thing is because the testing key population normally do not access traditional settings. So when you have the community going there, providing educations and provide a way to communicate, I think it helps you to overcome that fear and also link you with services. So it's not just providing information one way, but also you know who to contact and that person actually hold your hand, go to get the test result and also linking you to facilities. And I just want to end by asking some questions for consideration, and I hope you get take-home messages with this slide. That when we talk about key populations, I think we need to acknowledge that there are diversities within this group, as Ken highlighted in the presentation. And also we know very little how to provide pre-ART care for key populations. They turn up for tests, and then they're not eligible for treatment yet, but they will lose out to health facility. And without component of community-based service delivery, I think it's really easy for the person not to show up again for HIV treatment, especially when now the science are telling us that new early treatment is beneficial, but if the key population do not turn up, then I think it doesn't make a lot of sense. And the biggest question is how to incentivize these people to come back to health facility. Then I think from the policy and program perspective, I think that needs to be taken into account. And we know that that I'm running out of time, but I just want to highlight a few things here that we have to be more open about social media to engaging with key populations. We need to support the local initiatives that really make a difference and try to promote demand for HIV testing linkages to care. Of course, the issues around law, legal environments, ethical standard. How can you perform testing without undermining the human rights of key populations? When you talk about VCT at work, what about sex work is not recognized as work? What can you do to make sure sex workers have access to testing? And what the positive communities have been saying is that we want to put an end to mandatory HIV testing. But we started to see that play out in many countries, and that's not just for key populations. And lastly, I think we really need to have conversations about advocating for communities to be an equal partner in delivering HIV testing services at national level, because a lot of us who provide services still have issues around convincing the Ministry of Health to agree and acknowledge the added value of our work. So that's what I want to end my presentations. Thank you. I hope you're still awake.
Thank you very much.